So we'll just give it a few moments to let everyone start to join, and then we will get on with workforce planning for managers for this year, 25-26, and we'll go through that. Okay, everyone looking like quite a small group today. We are talking today about workforce planning and going through what you need to do to organise workforce planning within your surgeries. Today's meeting will be recorded, and the recording has started, so please do keep that in mind if you were planning to put your cameras on, and making sure that you are on mute. Obviously, it's bad enough when we're teaching if someone wanders in your room and gives you some amazing piece of gossip that is spread right across Manchester at that point, but when it's recorded, then it is there forevermore. So we need to keep ourselves on mute unless we're asking a question. There will be a chance for Q&A, and slides and handouts will be emailed to you at some point after today's meeting. I don't deal with the admin side of things, so please be aware that that will come out directly from GP Excellence. Don't be looking for my name on the email. It will be coming out directly from the inbox there over the next couple of days to make sure that you get all the handouts that you might need. If the slides stick, let me know. If there are any problems, let me know, and we'll do our best to sort it out. And hopefully we will get through today at a nice pace with quite small numbers on here. So hopefully not a ridiculous amount of questions, but anything that you do need to ask, please do. No question is silly. So we will happily work through whatever you need to know. Why am I here and who am I? Well, some of you may have been on my sessions before, others of you won't. I have been a practice manager for many areas over many years. Different areas actually helps my knowledge and understanding with things around things like workforce planning, and that's because when we are looking at workforces, they may differ in certain areas. Some areas that are lovely and leafy and really nice may not have the same needs as some of the poorer, more challenging areas where maybe you need help with drug officers or alcohol officers and those out of the box type workforce that you may be having in your surgery. There's certainly some homeless practices and things where there is a need for a different type of workforce. So we will briefly cover that, but we are going over the mainstream workforce of today. Going back to, as I said, practice manager, several areas over the years. I am currently supposed to be retired, although I am locuming at a practice who has had some issues with CQC. So that's what I'm currently doing. I'm also a trainer and mentor for the Lancashire Training Hub, the LMC for Lancashire and Cumbria, and for you guys over here in Manchester under GP Excellence. I also privately consult in estate. So although I'm retired, not so much at the moment. Our discussions today is going to be looking at some workforce planning. It's going to be looking at skill mix and your current teams, and not to overlook people on your current teams that you may be able to move forward and put into better positions to help future-proof your surgery. We're going to look at communicating your workforce to the ICB, which you are supposed to do through your workforce planning tools. And we're going to have a brief discussion on succession planning, although there is a whole session on succession planning planned for December. So that will be a area where we'll look deeper in December at going over the particular paperwork you need to have, because people like CQC do ask to see your succession plans going forward. But I've seen some people have only just joined, just to let you know that this session is being recorded. So keep yourself on mute, please, if possible, and be aware that everything is being recorded. So your first stage with your workforce planning is to look at the workforce you already have. This may sound really, really obvious. It's not always obvious to everyone, so this is why we mention it and talk about it. And the reason we do look at our current workforce is, firstly, we want to keep our current people. And sometimes they feel they're overlooked if they don't have the opportunity to move onwards and upwards into new roles. It can be quite surprising. You may have reception staff who are actually really longing for a clinical role and maybe looking to start a phlebotomist role or an HCA and then move onwards and upwards. I've certainly had receptionists who have actually ended up being nurses over the time, and because we've supported and stayed with them, we've got that valuable practice nurse with some experience of the practice that stayed with us all the way through. It's certainly a lot of staff, and some of you on here may be in this situation where you've started in reception or in admin and have ended up being practice manager. So if we can keep our teams, it's certainly an easy and defined way to keep people working for you, and you will always know what they are like, whether they are the kind of people that turn up on time, whether they're organized, whether they are good at being in and not being off sick long term quite a lot, because that makes a difference when you are going upwards in the role, and knowing that you can rely on certain people is really useful to know. The cost of recruitment is really expensive. Some people will think, does it cost anything to advertise? When we start really looking into the real cost is the manager's time. Think about your hourly rate and how much time you spend drafting an email to attach to an advert. Then you upload that advert onto NHS Jobs. You inform your team. You may be putting your advert out on other places. Each time you're doing that piece of work, then you're going through everyone that has applied, looking at all of those applications, putting together maybe pre-application checks and tests, going through, sitting through multiple interviews, all of that. If you start working that out in both your hourly time, but also anyone else that's sitting with you. So if it's you and your reception manager or your assistant manager who's doing the interviewing, it's their time as well. If it's starting to involve partners, clinicians, then it gets a very costly time when we're starting to look at all of that work outside of practice when we're recruiting. So that's why we start thinking about, can our staff be upskilled? So we need to start looking at the staff we have and then planning for the future to make sure that we have got plans in place for things that are happening. So you need to look at your current skill mix and then find ways of learning to teach within your teams. Please don't just assume that everybody wants to teach. They really don't. So if you have some very senior members of the team and some new people coming in, it is great if they are happy to show them, teach them, and then watch them as they go through learning a new skill. But do please ask that person first if they are happy to do that. Not everyone feels comfortable in teaching, and if it is not written within their job description, please don't force people to teach. But if they are happy to, it's a great way of teaching within your team and upskilling your current team. Also look at all of the different bits of free training there are out there. You've got a training hub and you've got GP Excellence, and between them they do have various pieces of training. And don't always think that management training is just for managers. It might be for your assistant manager or for an operations manager or someone up and coming, that they can learn to do parts of your job. So we can upskill all the time as we go through, and that upskilling really can assist you in keeping your workforce working properly. So you need to plan for a workforce plan. We're going to provide documents that will come out to you that you can work through, first of all, to see what you currently have in place, and then you can use this workforce plan to work forward and put in place maybe some teaching if you've got people prepared to do that, or looking at outsourcing some teaching if that's necessary, because then you can see exactly what you've got within your current team and where you need to improve. Never assume that you just have the right skills already, so there's no need to train people because everything's running just fine, because people leave and people get sick. It only takes one person that's really key to things that suddenly goes off sick, and it can be completely unexpected, and it can be long term, and then you can find yourself in trouble. So it is always really good practice to have at least 2 people who know how to do everything, and to have written protocols of how to do the most basic of things within your practice, so that if somebody does go off long-term sick, or if they do hand in their notice with immediate effect, you have got immediately a way of being able to cover things, because you will have protocols and policies in place that you can work through those protocols and make sure they're really simplified. Always assume if you're writing a protocol about how to do something, that you're doing it from the most basic point of view. So that might be click the button at the top, the third thing down says such and such, click on that, that will get to the next stage. Really do it as if you're teaching a 10-year-old. Don't you be going writing all the protocols unless they're protocols about something only you do, but make sure protocols are in place by getting all of your team members to start writing protocols about every part of the job they do, so that this knowledge can be passed on if it is needed. So we'll start with doctors. You'll have quite a blank sheet to work through, where you can put through your doctor's skills, your doctor's the names, and then the skills that they have, and we're going to work through and work out what skills that they can pass on and teach other people. Don't always assume that senior doctors are the ones that know everything. They may be new doctors to you with speciality areas. You may have a doctor that is young and not far out of training, but actually they have specialised within their training by working in particular departments in the hospitals, where they have a bit more understanding on something, and you can use those PLT sessions to improve your workforce by teaching those things across. One really important area to think about, where our more senior partners are not normally the experts, they might be, but not normally, is AI. AI is coming in, whether we want it to or not. It's in the 10-year plan that everybody will be trained in AI. And when we have to all go through that training in AI, that includes our doctors, and the best people to teach is clinician to clinician when it is looking at AI within consultations. So it's a really good idea to look at championing things now, and look at things such as Heidi that put things into their consultations, learning those skills, and that can often be your younger, more keen doctors that will actually come in and teach your older doctors how to do things. So it's not so much about who teaches. I can't tell you that today. You know your own workforce, but it is thinking outside the box. Don't always assume the most senior person in the room is the one with the knowledge. It can work both ways depending on the subject. Have you got GPs that will actually learn from other specialities? Some of you may, some of you may not. You again know your GP partners or your salaried GPs, but it's always worthwhile thinking in a session for your PLTs, or whenever you have a training time that you can possibly do things, that maybe if your pharmacist wants to do a piece on meds management that he would find useful to share, that's something that could be really useful. Or if one of your nurses wants to do a session on diabetes or respiratory and do a teaching with the doctors, that can upskill your doctors. And when your doctors are upskilled and a bit more trained, then you are covering more areas in the surgery. So we need to think about that within our workforce plan. The old-fashioned way with the nurses before it was all going to university and getting our degree was show one, teach one, do one. That's actually still a really useful skill to have, particularly when we've got our nurses maybe that are supervising our HCAs or our nurse associates and working through that show one, teach one, do one, where they will show them how to do something. They will teach them a little bit about that particular area. So that might be, say, we'll use phlebotomy as an example. They might be taking blood, and they will show them that. They will go off on a training course, but when they come back and put that training into practice, your nurses should be signing off your staff, your HCAs, etc., to show that they are competent at doing those areas. And if you can get those more and more people with competency checks, that means your workforce will be in a better position. So we can look at competency assessments across your workforce team. So when you're workforce planning with your nurses, always a good idea to have a workforce plan. This again will be coming out to you after this session, where you have various skills that you need to use within your particular surgery. That may be different in all of your surgeries, so just feel free to overwrite on any of the bits at the top if it's not something you do. When this was first made, it had ear syringing on there. Many practices don't do ear syringing anymore. If you don't do it, remove that. You may be thinking about diabetic checks, childhood IMS, ECGs, anything that can be done, HCA or nurse, that we can start filling out along here. You can pop your staff member's name down and you basically RAG rate it. Red, amber, green. Can they... No, they can't do it, but it's something you want them to do. Amber, yes, they sort of can do it. They've attended some training, but they're not completely there yet. And green, absolutely competent. Obviously, there's a white in there, which is not applicable, and our not applicable is when we've got someone that shouldn't be doing something. So obviously, if you have an HCA, it is not within their competency to learn how to fit a coil. It would be completely inappropriate, so that would go down as not applicable. You need to get all of your staff on one of these workforce plans within that area to ensure that you are getting the most out of your team and making sure your team has got plenty of cover for you as part of your plan, so that you can prepare if somebody goes on maternity or somebody leaves, that you've got that little bit of cover. Do think outside the box when you're planning your workforce. We have a smaller and smaller amount of trained practice nurses out there. You may be taking on nurses from hospitals or from other fields. I know I've had a few midwives that have come in and they've been great at sorting out baby checks and sorting out various areas to do with women's health, but it's been going right back to basics to start teaching them how to do things like diabetes and asthma, and there's been a lot of training courses to go on. That can be quite expensive, especially if they've come in as a senior nurse from somewhere else, so they might be coming in already on a band 7, and actually they're brand new to practice nursing, so you are paying quite a lot of money while you're upskilling. But there are other roles out there, so we can think about things like nurse associates. They are not just for PCNs and ARS roles. You can have a nurse associate that works directly for you. And the important difference between a nurse associate and an HCA is the nurse associates have a PIN. And having that PIN means that they can learn a lot more areas that an HCA is not allowed to do, such things as cytology, smear training, certain areas of chronic disease that go that little bit further than we would allow our HCAs to do. A trainee nurse associate is a band 3 in general. Even if you don't use Agenda for Change, you can look up the Agenda for Change pay, and that's kind of where you're expected to sit at. And when they're qualified, it's only a band 4. So that it's quite a junior band in comparison to our nurses. If they do decide they want to go on and do their nursing, it's only a 2-year top up rather than that great big long nurse course. So that means that you can actually have one working for you and topping up to be a nurse with maybe an agreement to stay as part of your succession planning. If you keep your eye out on any emails that come out to you about training, there are often free training to upskill them up to nurses. So it is definitely worthwhile thinking about that. They will disappear off on placements, but on the long term, if you back up those staff members, there's a good chance they will be staying with you to learn and teach future generations. So be there as part of your great succession plan to work further forward. And continuing on with the nurse part of your workforce plan, a lot of your AMPs or any other advanced practitioner role, potentially there's R's money. I would always look at your PCN, depending on how your PCN is set up, and see, is it feasible that we use some of this money to actually get some practitioners into practice? If not, do think about your staff succession planning moving onwards and upwards to be able to do some of these great areas of work that they can do. They are cheaper than a GP to cover the easier day-to-day appointments, rashes, your coughs. It's great because you can grow your own, so you know that they are yours, you know how they work. And they can also take on some nurse management. So delegate, move out some of that management role that you're doing and get someone that's in a lead nurse position to take over some of that big amount of work that you are probably drowning in at the moment. They should be appraising the nurse team. They should be working through holding nurse meetings and make sure that they are doing that as part of their role. You will have to give them a bit of time for that, but that will take a lot of pressure off you as part of your workforce time. And there is, of course, this new role that's come out. I think we're all a bit wary of this at the moment. It's called a consultant nurse role. There's not many of them out there in general practice at the moment. But you may have an AMP that's itching to move onwards and upwards. And at one point, that would have meant the only consultant nurse roles were in hospitals. They would have been leaving you. So think back about that recruitment cost. Can we keep these people? And if we can, they may be having to look at these consultant nurse roles. There is R's money for consultant nurse roles if you still have any budget in your R's. The discussion in the 10-year plan, if any of you have read the 10-year plan, is that they will be the lead in clinical management and clinical research. They are looking at giving them a much more clinical management style role so that your GPs don't have to keep disappearing to meetings. So it is worth looking at and considering. It is a high pay bracket for them. So under ours, it's an 8C. It is just worth having a look at how much money that really is. We're sort of talking trying to remember, 70 to 90,000, something like that. It's right up there. So you need to be prepared that these are going to be an expensive staff member, but still cheaper than a salaried GP. So you've got to balance that, but make sure it's appropriate for the role. They are not GPs and they shouldn't be working as GPs, but they may be able to take some of the easier stuff or some of the management role away. We also have pharmacists. These don't have to be done through ours. If you've got ours money, again, you can, but a pharmacist can take an awful lot of pressure off in your practice by doing all the meds management stuff, a lot of research. They can take charge of certain diseases. Hypertension is often done through your pharmacist. There are also pharmacy techs. So pharmacy techs are roughly an Agenda for Change Band 5. They can do certain things to take pressure again away, working through your prescribing areas or for your audits to make sure you're up to date. So it is worth having a little think about those other roles. We're now going to move on to admin. So with our admin team, you need to look very closely at your admin team and think, is there a future for them? where they feel they want to stay. Because again, the important thing is to try to maintain your team. Do you have team leads? Sometimes it doesn't have to be about big amounts of money. It depends on the size of your practice. If you've only got 10 staff, you probably don't have masses of team leads. If you're in a great big practice, I really like a team lead position, lead secretary, lead communications, which is taking charge of some of that AI stuff. And also your websites and all those kind of good bits, your IT lead, all of those things. It's not always a massive amount of money. Sometimes it's about giving people that chance to improve, to attend certain training and to be able to move forward, so they feel that they have an opportunity as they go through to improve themselves for perhaps a future management role. So that leadership is that first step up. It will also take a lot of pressure off other people, because certainly yourselves, because in those admin roles, I have always made my team leads do things like some of the lower teams appraisals, so that then you're not doing everything. Maybe with you sitting and learning and teaching them how to do that, because that is part of your workforce planning, is teaching your team how to improve and work better. So think about improving from within, and as we mentioned before, a protocol for every single part of their role. And you can work through one of these, which will come out to you for your admin team, so you can think about things that they can do. And we can look at these skill plans to work through from the team. So we will have a team name, my goodness me, I'm so sorry, a team name down, and then we have to think about each area. Can they do this particular piece of work? Can they do that with support? Are they good enough to teach somebody else how to do it? And we work through those questions so we can start forming a plan, and we can see actually how our team is sitting. Have we got enough cover in every area? One of the phrases that I often use is that hit by a bus scenario, which is if somebody is hit by a bus, could somebody else pick up that piece of work? Because it's not always the expected. It's no good thinking my staff will stay with me forevermore because this is all they want. People do move on, but also there are those unexpected scenarios. Somebody could hurt themselves and be off work for 6, 12 months, and we have to know what to do and how to replace them to make sure that the practice can still keep running. All staff are going to need to go through AI training. As I mentioned, it's in the 10-year plan, and by 2027, you have to have all of your staff having done AI full training. Probably a really good idea to look at a champion for this now. So not just a clinical champion. So we talked about maybe having a doctor, but how about an admin champion that can take this forward and start teaching maybe your reception staff and your admin staff? I am quite happy to admit, being that much older and being someone who is going towards retirement, or I am actually retired officially. If you are retired or getting towards that age group, AI may need that little bit more help for you. Not everyone. There are certainly some people who are in their 50s and 60s that are fantastic at this stuff, but quite often it's your 18 to 21-year-olds that are really up there. And actually that's where they can champion in things and take some pressure off and teach, hopefully, if they want to, and it will give them that lovely skill for the future that maybe they are moving forward and in one day will be in a more leadership role. So a champion for something can be really helpful in giving people confidence and learning. I think on that, just to add to it, I realised that this isn't just me. When my 27-year-old son didn't know how to do something with his computer, and yes, he is absolutely superb at that sort of thing in a very high-powered job, and the office apprentice, who was 19, I think, came over, touched a few things on his keyboard and said, maybe you're a bit old for this. And my son's 27. So I think Sometimes you're old even when you're young. So we do need to look at our younger members of the team who perhaps have that bit of understanding in certain areas we don't, and allow them to champion in things, not just our senior people that have been around forever. So work with your team, learn their strengths and utilize those strengths, and they will actually enjoy that, hopefully. We're nearly halfway through the slides. We're only half an hour in, and just wanted to check on you. Has anyone got any questions so far that they want to pop in the chat if they don't want to come off their mic? It's been very quiet so far. If you haven't, that's absolutely fine, but I don't want anyone sat in silence worrying. No? Okay, I'll keep watching that chat if anyone's got anything there. So outsourcing is going to become a big thing and a big part about our workforce planning going forward. If any of you came on the 10-year plan training that we did, the 10-year plan suggested that we need to start thinking about having shared office staff across PCNs or even wider. So that might be sharing your staff. So if staff start leaving, before you immediately replace them like for like, maybe have some conversations within your PCN. Is there some shared back office work that could be done right across? Some people have gone as far as having all their receptionists working and booking into 3-4 different surgeries. That is a really big piece of work to put into place, but it makes sense. But bear in mind with that, you all have to have your appointments running the same way. If you don't work the same way, it will not work for you. Some of your online consultations, you really got machines doing some of that initial bits where you're getting people loaded in via patches or Accurex or whatever you're using, that you're getting people uploaded and worked in through by going online to do things. This is all part of the same thing. You can outsource read coding these days. You can outsource summarizing. There are all sorts of jobs out there. There are secretarial MedSec jobs that there is someone sat in an office miles away that you can upload your recordings to, and they sit and type them. I know things like Lexicon Scribe do that. It's all worth looking at, because when you are pricing up how to organize a new secretary or a new coder that comes in, all the training that goes into place, sickness, people leaving, annual leave, paying national insurance contributions, pension contributions. If you do a bit of a time study on some of this and you outsource to a company, sometimes there can be some really big savings. Also space. If you are running out of space and 2 or 3 of your admin staff leave, before you replace something, could that space be made into a clinical room? Could I outsource this piece of work? Could we learn to work together? We are being told in the 10-year plan that AI is going to be covering an awful lot of these types of jobs. And therefore, are we taking on new staff now, when in fact, in a couple of years, maybe we won't need that many staff? So you need to start looking 2-3 years ahead and thinking, what's around the corner? What's coming in? What can I change? Minute taking is a really big one. At the moment, we can actually stick things on Teams and transcribe as we go. So therefore, we will have minutes for that meeting transcribed. And therefore, sometimes you don't actually need actual minutes. Or you can video and take conversations. As long as everyone's happy with that, you can video a meeting and use those videos as part of your minutes in video format. So there are all different things you can do to save having, say, a minute taker available, and this can save you money in your workforce planning. We start moving on to receptionists or care navigators or whatever you are calling your reception team at this time. You should have a reception manager if you have a big enough surgery, who will be able to teach and delegate towards other members of the reception team, teaching them how to do various things so that they can get things done correctly. And there is a workforce plan that will go through this. And we do put lots of different things on this workforce plan, because we are working through that same skill that we saw earlier, which is don't know how to do it at all, know how to do it maybe with some instructions in front of us, confident at doing it, not confident at teaching, confident at actually teaching this to a new person, etc. So we can work through to make sure that we can figure out, can our reception team function and know how to do all of these little bits that they need to do to actually assist and help. And a good reception handbook at induction with all your protocols and things would really help to work through this. So some of the ideas we're looking at with those with that particular area of work is things like, can they book an appointment? Sounds really obvious, but we need to make sure they can do that. Do they know how to cancel a clinic? If they are the only ones left in, somebody calls in sick for the next day, do they know how to cancel that clinic? Do they know how to deal with our opening up the building or closing down the building? All of those sorts of things, there should actually be a written skill mix. And this is the kind of thing that CQC are going to ask you to have a look at so that they can see that you are a safe practice. So that is quite important that we work through these areas and we know that our staff can do all of these things. Really good idea to also have maybe some IT stuff on there. Do they know how to reboot their computer? Sounds really obvious, but honestly, I've had people phone my IT lead to come and put their computer off and on. Normally clinicians, it has to be said, but these are the things that people need to learn how to do themselves. Back to our reception team, do they know what they're doing if they have to hand out physical prescriptions? I know most things aren't physical anymore, but do they know how to do that? Do they know how to take the money? If you are charging for things, if you are using a machine, do they know how to use it? If you get this workforce plan all filled out, then you can look at who doesn't know how to do things, get that teaching put into place to work forward so that they can become more skilled. And then we can't have that conversation of, I didn't know how to do it, because you are going to organise within your ones that feel confident which of those are prepared to help you teach. And yeah, it can be in a teaching session. If you have a PLT afternoon, you can get a big screen up, hopefully, and you can maybe get your reception manager to teach a skill to the reception team that are there. It is all worth thinking about rather than getting in more and more people. Do you need this amount of people when there are machines out there that can do certain things? Can we utilise our team doing something differently? And that should really be able to help you to move forward. Excuse me. I know in Manchester there are not many dispensing practices, but there can be the odd one or two out there in the slightly more rural parts. So therefore, if you have a dispensary, it is a slightly different thing. You do need to have Buttercups training or a similar provider. You can't teach one, do one. You do have to have that qualification, but you can have internal learning. So you can have your reception, your dispensary leads teaching your more junior members that are coming into dispensary. And often you can upskill from receptionists that want to learn something different and they can move into a dispensary role. Moving straight on, because I know that many of you don't have a dispensary, so that's just a little short slide for those of you that might have. Your biggest area, really, apart from your clinical areas, is your practice manager's role. They do say that you need to build a team so strong they don't know who the leader is. And that is really that your team that are around you should be all very strong. Do not be afraid of somebody chomping at the bit for your job. If you are competent and good at your job, it won't matter that somebody is desperate to learn. It is actually great to surround yourself with people who can work at a really, really high level. You do not always have to be the best in the room at everything. I always like to think of practice managers as in a similar manner to the way you may think about a hospital consultant. As a consultant, they don't see everyone. They don't go and take the bloods. They don't do the easier appointments. They just oversee and make sure everyone else is getting things right. So if you've got a really good, strong IT lead, a good operations manager, someone that's great at sorting your HR, that's fantastic, because all that strength just will make your practice stronger and will make your life a lot easier. So don't panic about people that are coming up and maybe want your role in the end. It's great to succession plan and teach them so they can have your role in the end when you've decided to retire, leave, work less days. Some of that pressure can come off you. So it is really important to learn to delegate. Some of you will be brilliant at delegating. Some of you will be absolutely terrible and want to micromanage it. And it is learning how to delegate all the time and work and train your team. So it is good, again, to have a management area here where you can put your staff members' names and then put across here different management skills. Now, each of you, again, are going to be different. So there will be such things that will be coming out to you, like payroll. You may outsource payroll. If you do payroll in-house, you need at least a couple of people that can know how to run the payroll system. Pensions, SG55s that need to go on once a year, really mind-numbing jobs. So always great as a bit of training to maybe have your assistant manager do those at 1 year so they know how to get those on and work at that. Making sure you've got HR training in place so that your assistant manager or your ops manager knows how to form a contract. If you went off sick and you had a new member of staff, could they put a contract in place? Could they recruit properly and safely? Do they know how to get a DBS check? All of these things you can list on your workforce plan and tick off as you're aware that they know how to do them. Do not be afraid of having successful and good assistant managers. Just think of it as a chance that when you're sat on that beach for your annual leave, you can stay there, enjoy it, and not be phoned every 5 minutes. Don't be afraid of sharing. A really good manager shares and teaches and moves their team up with them. And do learn from them, because just like we mentioned with the AI, sometimes they know stuff we don't know because we've always done it one way, and there might be a quicker or better way. So always learn from others. Always helps to keep a practice really strong. We had the 10-year plan. That came out, told us quite a bit about the stuff we've talked about. But we've now been told there is a 10-year workforce plan. They've said it's coming out by the end of the year. They haven't got long because we know the MPs closed down at Christmas. So we've probably got a couple of months, 8-9 weeks, and then we should have this workforce plan coming out. And that is going to apparently give us hints and tips on how to work forward within the regular 10-year plan to learn what is coming in. I would strongly advise when that comes out that you get a copy of that workforce plan. You'll be able to pull it down from NHS England because that's still going for a little bit longer. And when you get that plan down, go through it and see how you need to move forward, and then rework your workforce plan towards those things. So we've had lots of hints about AI. We've had lots of hints, and we know now you've started all your online consultations, which I know has been really tough for a lot of you. But that's in place. We know that there are a huge amount of new HR rules coming out over the next 2 years. We need to make sure that we are compliant with all of those things. And this 10-year workforce plan, we understand, is going to help us understand that. It's also going to apparently tell us about how health and social care and the NHS will work together. So it is worth having a look. And if it's something you don't need to be doing in your practice, because actually it's something that falls under health and social care, then maybe look at what things you can stop doing rather than taking on more and more staff to cover things that somebody else is being paid to cover. When you start working out your workforce plan, look towards 3 to 5 years ahead, really. You can't just think about 1 year or 6 months. Now, planning 3 to 5 years ahead, there are no certainties. Absolutely not. But we need to think about not just replacing people, what is coming forward, what people are likely to leave, so you can have natural wastage. You don't really want to be making people redundant, but if a whole piece of work is going, then we can retrain those staff, and maybe when somebody leaves, retires, goes on maternity leave, we don't necessarily need to cover that role. We need to think outside the box a little bit more. So the considerations you need to have when you're planning your workforce is your staff budget, which is getting worse because obviously the national minimum wage is increasing. We've had the additional pressures of the employer's national insurance money going up. We've got to think about the terms, conditions, annual leave, maternity leave, all those extra costs that come in when we have a staff member. So don't just think about their normal budget, think about then if they're off sick or on long-term leave, are we covering them as well? Think about your recruitment, think about retaining your staff, and then work carefully through induction processes and reviewing and competency assessments. Really struggling with that word today, I do apologise. We need to consider the training and development of our staff. So we work forward. We all know that each year something new gets thrown at us. We'll get a different les that will come in that will require us to know something different. And we know that there is going to be a lot of hospital work over the next 5 years that is going to be brought into general practice. Some of that started to happen. There is a lot more coming. These are going to be things that will be paid, but we are going to have appropriately trained staff. So you've got to plan to improve. So sometimes you will need to release your staff to go to that training, even though you feel you don't have time to, because in the long-term plan, you are going to need them trained to take on these extra roles if you plan to do that. Flexible working is now really, really big. We have to consider our staff for flexible working. So we do need to consider exactly what we can afford to do with these staff, because we have to show consideration if they want flexible working, and what we can do to make their work better so that they stay. Do listen in appraisals. I know it, and train your team who are doing appraisals to listen to the things that aren't necessarily stated but hinted at. So if you have someone in an appraisal that mentions in the next 3 to 5 years, I think I might want to reduce my hours, worth having that conversation with them now. Exactly what did you mean? What can we do to support you at that time? Please remember to come back to us. It's amazing those that hinted it, because they're applying for part-time jobs because they've never asked you. And then all of a sudden you've lost a really good staff member because they wanted to drop a day, but nobody was really picking up their hints. Yes, they should come to you, but try and listen to those hints, because retraining a staff member takes a lot of time. Do exit interviews. If somebody is leaving, you want to know why, because if they are leaving, you want to possibly know if anything you have done has made them leave. Is it that you haven't given them opportunities where they can move up? You may be able to do something about that. You might not, but you might find giving them a little bit of training so that they've got that hope in the future might help. Are they really unhappy about something? Is there something you can actually change by looking at their exit interviews? Obviously, if someone's retiring, it's completely different because they're going because they want to stop work. And then what you need to do is start looking at mapping out your workforce. So we need to plan and look at demand and capacity, and then look at any resources available by training and development. So can we develop a staff member to plug that gap that we have now found on a certain area? Identify our strengths and weaknesses with our team, and improve our employee opportunities for possibly promotion, or at least feeling trained. And even if it's a tiny bit more money, giving them a little bit more responsibility sometimes is enough, even without more money, to give them that hope that one day they will be in that leadership role they want. Look at increasing our productivity with our processes and systems. Can we put in things in place that we're using a machine to do something? Some things may take a bit of time at the beginning to get going. Might be something like you're digitalizing a system, and when you first go through it, there's a lot of work to get everything right. But once it's in place, it will run quicker, smoother, and with less people. So you've got to think, is there something you can do to avoid bringing in more workforce than you actually need to save that bit of money in the end with your planning, and to make sure that you've got enough space for all that workforce. So when we're mapping out our staff, we need to look at what we need, what new things are happening in the new contracts, and what are we guessing, because it is a guess, what will happen in the next 5 years or 10 years. Part of that is looking at that 10-year plan and thinking, if Labour stay in power for the next 10 years, if they bring this plan forward, what's in here that is going? So as I've mentioned, AI will be taking over a lot of stuff. Do I need staff members trained in these new areas? Yes. But do I really need to have as many people? So for instance, if all your consultations and lots of stuff is going through, people are going through Patches or Accurex or whatever you're using to book appointments and things, that can save time. I know when the COVID backs came out and we were sending people self-booking links and people were booking, if we had had receptionists doing that job, we would never have got done. So the more people we encourage to use the NHS app, the less reception staff we need in the long run. And then we can slowly get our appointments online and get some online booking in there for certain things, not everything, but certain things. And certainly once those people are trained, and by those people, I mean our patients, when our patients are trained that actually it's quicker for them to use things online, you will start to be able to reduce your workforce a little bit by natural wastage as people leave. Don't assume you know what skills people have. Ask them. You may have someone that secretly loves really interesting bits of stuff to do with computers, IT. They are longing to get involved with something, but they are not really the kind of people that will come up and tell you. So before you go out with a new job, one thing that I have noted with lots and lots of staff is, with lots and lots of managers, is they don't send out things internally and say, we're looking for someone to take over safeguarding admin or our end-of-life palliative care meetings. Is there anyone here who has an interest? And it is amazing. People come out the woodwork that you would not expect and say, actually, I've always wanted to do that. And then you can move upwards into a higher based admin role maybe, and then recruit from below, which always means that if you are keeping your staff moving onwards and upwards, they are happier. You won't always have roles to do it in, but if you do, keep it in mind. Use your appraisals to find out what your team wants, what they're interested in. Is there any training? If there is free training out there, if you can just spare your team for an hour or so, team members to go and do that training, you are more likely to retain that particular member of the team if they're a good member of the team, because they will feel valued, and valuing your team will keep them as part of your workforce. Use meetings to explain up and coming areas that may interest people. So these are the things happening in the 10-year plan. Is anyone got any interest in that? Does anyone want to help take this ahead? And then you will also share your workload out, because you don't have time to do all of this stuff. I've been asked to mention on here the workforce tool, which is the National Workforce Reporting Tool. If you hover over here, you will see where that is. This is supposed to be completed every month. You are supposed to be completing it on behalf of your practice staff. If you have a PCN manager, your PCN manager should be completing it for PCN staff. If you are both the practice manager and the PCN manager, you should have two different ones to complete. This is apparently not done very as well as it should be over the Manchester area, and lots of people are not completing the workforce tool. It is contractual. So we do need to make sure that that's done to help the NHS plan and know ahead. And as it is part of the national contract, we may have to make sure that we do our bit and have covered that area of work. So sorry to mention it, but it is something that you do need to be doing as a practice manager, or have delegated that piece of work to a trustworthy member of your team to do that and keep up to date with it. Everyone okay? There's no questions gone in, so I'm just checking. Yeah. Okay. Really good to think about our staff and what they can do for you. Thank you. I was just seeing a thumbs up. That's made me feel better. You are all out there. What can our staff do for you? Again, it's worth thinking outside the box. It can be really, really challenging depending on how your PCN is set up for me to be able to answer what your staff can do for you. Every PCN is different. Some are limited companies, some are working just in the old-fashioned way with a lead practice. Some of them really don't like each other, so they muddle along. Some of you will have staff who are working just in your practice, but are paid for by ours. Anyone like to add into the chat anything they do with ours that might be helpful for other people to know? Oh, Rachel, sorry, has just added in workforce data. I have been told you have to go in and out of each staff member and save to be completed correctly, not just when changes occur. Not every month. We've always, as long as they've been put on correctly in the first place, you should be able to leave those alone and just add them on as you go through them, as more staff come. Occasionally, and it will flag up, it will show you and have a sign on there. I think it's red. I'm trying to remember, it's been a while since I've done workforce planning on their workforce data. You generally have, it will flag up if something new has been added. So I think about 5 years ago, they added something new that we had to add in for everyone. I can't remember what it was now, something of nonsense. And we had to go into every staff member then because it was just a new question, but only once. It's certainly not every month. Thank you. I can see Jenna has answered. That's not correct. I have checked. So that's great. Thank you for that. This is why it's great when you all come in. So yes, you do need to go in and check. So log in and check your list, but it doesn't mean you have to go into each staff member and do anything. So hopefully that makes sense. So back to your R staff. Any of you doing anything that is useful, helpful to know that maybe is a little bit different than other people, please pop it in the chat. It is really helpful for each other to know. Are you using them to go through your local leses? Is there anything in there that perhaps you're using someone that's a little bit out of the box, basically? I mean, in my last practice, we had a pharmacist who was really interested in new ways of working, and he started a massive audit and a piece of research work that he was that the practice were making money on and paid for on genomics, which was really fascinating when the 10-year plan came out and we were told that everybody has to work on genomics. So we already had a pharmacist that was now an expert in this, doing a lot of that work. And the practice was being paid because he was doing it as research. So there are things you can think about your R staff doing that aren't the typical job. We've also had our R's care coordinators looking at doing end of life MDTs for us, you know, leading on them. Obviously there's clinicians in there, but they are leading on getting all the stuff together, taking a safeguarding lead role, doing basically some small amounts of leadership, because if they're running through ours, they are generally paid a little bit more than our admin staff, fair or not fair. it's just one of those things. So we may as well utilise and get them working at that slightly higher level. Nobody come out with anything. I'm quite sure you do have our staff that are doing things that are a little bit different sometimes. I know we also had an OT, because they are very good at care planning, that did all our care home ward rounds, and dealt with everything to do with all of the people there, unless it absolutely needed a GP. So we completely released our GPs from dealing with our care home work, apart from in a complete emergency, and it was run very much by an OT. Joanne's put our care coordinator leads the admin for safeguarding and MDT alongside the GP, and that's exactly what we should be doing with our staff. That's fantastic. We're making sure that they are doing a useful role and moving forward, and they may do it just for you. They may work right across your PCN doing the same role, but we need to make sure that these staff are doing something to the value of what they're being paid, which is, as I say, quite often a little bit more than our reception or admin staff. So they need to be working a level up if they are. Dawn has put our clinical pharmacist does our CQC searches for high-risk drugs and organises our alerts. Yeah, fantastic. I've always done the same with the alerts and the CQC searches, and that's really good as well. And Jennifer has put, we find our staff only work well for the practice when integrated as part of the team and not kept separate. Yeah, it definitely varies place to place on how that works best. I find that is often the truth as well, but there are certain roles that can work really well working for everyone, depending on your type of patients. So when we had our OT, they worked across all of the care homes, because we had a large amount of care homes and she had a care coordinator working under her, and that worked quite well. Rachel has pharmacists, LCS and CQC searches, care coordinators, part of the PPG and attending dementia choirs and workshops. Wow. That is, see, it's all working. These are the things it's really important to share, because it might not be something someone else has thought of, and that's absolutely great that you're doing something that's really a bit outside the box, but also quite interesting for them. So you might get people who are actually interested in working a bit forward and learning something different. So that's great. Thank you, those of you that have taken the time to share, because it is really helpful to new practice managers to have a look at that and think, well, maybe I can look at my workforce plan a bit differently. We certainly had a social prescriber who was doing a lot of work with patients who were obese. We had a special plan for them in one particular area we were in, talking them through, getting them to join groups and things. So not only did they end up losing weight because they were busy then, they also weren't turning up at the doctors quite as much because they were actually happier in their lives. And I know that my husband works for a PCN as a health and wellbeing mental health worker. He comes from a mental health background, and he sees people in their own homes. It goes around for the entire PCN, and it's actually kept thousands, when we've done searches, thousands of hours over the year of GP time, because he has longer appointments sitting with these people rather than rocking up to the GP every day. So there are all sorts of things you can think about to think outside the box to actually save time with your practices, use your workforce properly. CQC are now asking, I know as part of my role, I am working with a practice who has had issues with their CQC. I'm also aware of 3 or 4 other practices, and I'm doing some teaching on CQC. And when I do that, one thing that's come up a lot is they like to see a formal succession plan. Really good to sit with your lead partner or a partner who specialises in HR. If you're in a bigger practice, they will have their own special roles, and have a look through to think about what would happen if a partner leaves. What if you're a single-hander and the partner wants to retire? Then what's next? Have a plan. Your succession plan should sit within your business plan. Hopefully you all have a business plan, but not everyone will. We are planning a full session purely on succession planning which is going to be happening at some point in the new year, I think, where we're going to go through with you mapping out your current workforce and making a 5-year plan. Thinking about who is likely to retire, who is looking to be promoted, if they want to be promoted, are there going to be positions with you, or will these people leave? And is there then a way of keeping them if they are planning to leave? Because that's obviously something that you're then back to that first slide, all the way back there, where we start looking at the cost of recruitment and how expensive that can be. We do have time now for questions. If you have any questions, it's obviously a small group today, and I think the recording sometimes makes people go very quiet. So this session will be a little bit shorter than planned if you don't have any questions. But just to let you know, the upcoming sessions are resilience for managers. There will be a finance session. If you join the finance session in, it's about July, it will be a repeat of that. It's not a new one. There'll be a responding well to conflict for managers in December, and the succession planning is in December. So there are different things up and coming that are going through. Obviously, I am happy to take any questions that you may have, but just to let you know that the GP Excellence team will be sending out lots and lots of documents after this. May take a day or two. I'm not sure who's in and at what time, but it will come out from them, and they will send you a copy of the slides that you can maybe work through with your partners or anyone that needs to understand and know workforce planning within your surgery. It will have copies of the different slides that we looked at earlier, so that you can, let me just get back to them, sorry. Your plans that look like this, where you can fill out for all of your staff, and you can look at what they are doing, what they're doing well, how they're doing it, whether they can train other people, and then you can start to put together your own workforce plan for your surgery to make sure that you have covered absolutely everything and you're not leaving yourself exposed. I would also take this time and opportunity to really start thinking about outsourcing and working together within bigger groups. So that might be your PCN. Are there shared roles that you can do, or shared even protocols, just to make things easier? If you're not great at working with others in your PCN, just have a look at what other things are out there as far as an AI area of work, or if we're looking at anything that can be a computer can do, basically, rather than you, if that can make things a little easier. So lots to think about, lots to work through. When you get all your workforce plan that comes out blank, I suggest you start working through that to help you plan better for the future. I hope today's been useful for you. Thank you very much for attending today. I know I'm going into your lunch break. If you're the kind of manager that manages to get a lunch break, well done. So apologies for going into your lunch break, but hopefully you've learned a little bit today, and thank you very much for your time. I'll say goodbye at this point. Thank you and goodbye. I'm just going to stop the recording.